So today I thought we would review active surveillance, but for the small renal mass this time, not for prostate, which has been covered before. And I think the different management modalities for small renal mass, which are becoming, with so many options, including ablation, partial nephrectomy, open, lap, has also been discussed. So I thought I'd combine these two topics to discuss how and when we could actively surveil a small renal mass. And I'd like to start with a case. One that is not uncommon to get as a consult from another service, for example, and just to take a survey of the audience. But if we had a 75-year-old gentleman that has a history of coronary artery disease and is pending a CABG and was found to have a 2.4 centimeter solid enhancing lesion on one kidney, with the other kidney being okay, and the consult comes in terms of the management for this patient, could we just take a poll of hands? How many people might want to treat this right away with a laparoscopic approach, let's say? No one would treat this right away, eh?
Nobody operates in Grand Rapids. I would never touch that.
What about some type of ablative therapy, needle ablation for a mass like this? Yeah, a couple hours. What about active surveillance in this type of person with this type of tumor? So a few more hands, still not all of them, which is fine for this time of day. But certainly there are multiple management options to discuss with the patient in this situation, going right from radical nephrectomy to nephron-sparing approaches. And then active surveillance has certainly kind of been on the background of management of these small renal masses for a long time and has been described in the literature for a long time, but never in a very organized fashion, which we will come across in some papers. But certainly, to consider active surveillance in a patient like this, there are two major factors to think of. And first are obviously the patient factors of competing health risks and things that might take the patient's life before their RCC-specific mortality, and also the tumor itself. And is this one of those very indolent, non-growing, or negative growth lesions, or is this an aggressive tumor with the potential to metastasize? And so these are questions that need to be answered in the small renal mass space. And so the objectives to hopefully cover some of these topics is to overview just the rationale for active surveillance for small renal masses, and then review some of the important criteria that are required for a successful implementation of any type of active surveillance protocol, and then review some of the available evidence, which a lot of it is retrospective, but there are some prospective studies too. So the first objective about the rationale for active surveillance really comes from 2 points: that the incidence of small renal mass detection is certainly increasing, and that many of these small renal masses have indolent behavior. There's no doubt that over time there's been a stage migration in RCC, similar to other organ systems we deal with, but certainly a T1 RCC is being diagnosed much more commonly, secondary to the renal incidentaloma, after cross-sectional imaging for some other reason. And in the T1 space, most of the lesions that are being diagnosed now tend to be even smaller than 3 centimeters. So, T1A, which is classified as under 4, but even within that, they tend to really be pushing for smaller and smaller lesions as we're detecting them earlier. And some estimates have put that the vast majority of these small renal masses will be incidentally detected in the elderly. So that conflict of having patient factors that may promote active surveillance versus tumor factors that might promote active treatment really needs to be discussed in this population. It's important to note, because for the talk I will be using the word small renal mass, but that does not always mean that that we're talking about a cancer. These lesions are detected on imaging as a solid enhancing lesion under 4 centimeters. And overall, 80% of them are malignant, and most of them are a subtype of RCC. But imaging alone, which is how these come to light, is quite poor at differentiating, for example, fat poor AML from oncocytoma from different types of RCC. So imaging cannot be absolutely diagnostic. And on the flip side of that, if the small renal mass is truly a cancer, it is not always one of these indolent or slow-growing lesions that we commonly see. But the CT scan alone does carry a risk of understaging with pathological upstaging because of microscopic fat invasion or other worsening factors that aren't captured on imaging. And again, the goal is to obtain to define the malignant risk of a particular lesion, and it's very difficult to determine how aggressive a particular lesion will be. Generally, those size has been taken as a surrogate for aggressive behavior. You can see that in several series here, the number of benign lesions is typically high at there we go. It's typically high at lesions that are very small, and then as the size of the lesion increases, the chance of it being benign also decreases, which stands to reason. But in some series, there's some paradoxical results where the majority of lesions under 1 centimeter can actually represent a malignancy. And so the overall number of 20% being benign under 4 centimeters needs a little bit of nuance to really appreciate that.
Samir, for the purpose of your presentation, what's your size definition of an SRM?
It's under 4 centimeters. Yeah, T1A lesion.
Are we going to review the nephrology score?
Not in too much detail, but I will be mentioning it. Yeah.
What the hell is it? You mentioned it on your case.
Yeah, that's right. So just briefly, because I do not have a slide distinctly on it, but the nephrometry score is a cumulative score with the acronym Renal, RENAL, which gives multiple things. Actually, it's been shown it can also give a sense of how feasible a nephron-sparing approach might be by considering where the tumor lies with respect to the hilar lines, with respect to vasculature, with respect to the collecting system. But also, some studies have actually used it as a prognostic factor, that lesions that have a higher renal score tend to even be higher grade. But I don't discuss that in too much detail here. But coming back to the size criterion, for small renal masses, many series cut it up in terms of lesions smaller than 3 centimeters and lesions that are 3 to 4 centimeters. And this is one of the fairly large ones, which was 287 incidentally found lesions that showed lesions smaller than 3 centimeters have a significantly lower risk of being PT3A or being a higher grade lesion. And this is where really size becomes the surrogate for aggressive behavior, because oftentimes it's the only parameter that we have. But again, small renal masses behave very heterogeneously, and this was just a very early study of an active surveillance cohorts over 10 years ago, just plotting the growth kinetics over time. And while most lesions do have positive growth kinetics, lesions that are biopsy proven malignant can have negative growth parameters here, whereas lesions that are biopsy proven benign can have positive growth kinetics. And so kinetics is not obviously the best measure of histology, but it's oftentimes the only thing that we have. The management for the small renal masses, as I'm sure the audience can attest to, is also heterogeneous. In that same study here, they followed patients on active surveillance, and you see the trigger for intervention is not some fixed criterion like a size criterion or growth parameter, but oftentimes the trigger for intervention is patient request with being uncomfortable about having the tumor being watched in the kidney, and some are surgeon concern over the interval growth. And again, that threshold is very caregiver specific. Just to highlight here that the different approaches are still possible after a period of active surveillance, especially nephron sparing approaches, and as expected, a small percentage of these resected lesions end up representing a benign pathology. And so it's important to try to get the best preoperative indication of what is benign and what is malignant, and again, how malignant it is. And these graphs come up often in this talk and in this literature. And just to highlight that the y-axis here is represented with different values often. This one is measured as the cube root of the volume to give a reflection of the total tumor burden. This here, some papers use actually the tumor size itself, so actual volume. But you can see if one dimension changes or if 2 dimension changes, the volume represented is quite sensitive to small changes. So graphically, it can raise concerns where there actually may be none. So it's important to see what the y-axis is showing. And again, not all these lesions are indolent. This was a large paper done by Indy Gill, a large review of the SEER database that showed even RCC lesions that are 0 to 1 centimeter still carry an RCC-specific mortality and still carry the chance of metastases at presentation. So it's not zero, and certainly as these patients are watched over time, the question is whether that risk of development of metastasis is being pushed up, and again, by how much. And again, on the flip side of that, the question is active treatment, though, having an impact on patient survival? And definitely in the elderly, it stands to reason that active treatment may not be having an overall beneficial effect on survival. And in this particular group of patients on active surveillance, patients that were treated for local renal tumors, age 75 years or older, the cardiovascular mortality in each group outweighs the RCC-specific mortality, regardless of the modality used, with fairly good numbers here. And once adjusting for patient age and comorbidities, then the actual management type and tumor size were not associated with overall survival. So certainly these competing health risks have to be considered. And other SEER data, just looking at competing 5-year mortality outcomes being non-cancer related death, death from any other cancer, and then specifically kidney cancer death. Age, again, is the most predictive of non-kidney cancer deaths, and when you stratify it out by size here, the lesions that are under 4 centimeters really carry an excellent RCC-specific mortality, and it's really where survival really gets impacted when the size of the lesion is greater than 7 centimeters, which again is not T1A and not the focus of this talk. So a lot of patients with T1A lesions will essentially pass from other causes. And this nomogram was established, and the author stated, to help with preoperative planning, and it's based on patients that were surgically treated. But just to give a general sense of these competing risks again, a 75-year-old gentleman with 4 centimeter renal mass has an equal chance of RCC death and death from any other cancer, but a much higher competing mortality of non-cancer death, again, cardiovascular mortality, etc. Whereas obviously a younger gentleman with a larger mass, at this point the RCC-specific mortality outweighs other contributing factors. With the increased incidence of detection of these 2 to 4 centimeter lesions here, there's been a concomitant increase in renal surgeries, as we know. However, the cancer-specific mortality for the lesions smaller than 4 centimeters has not been dropping drastically and has been fairly stagnant, if not slowly increasing over time. So this is really an issue in RCC management, how to best impact overall survival, and whether that's best achieved by immediate active treatment versus active surveillance with delayed treatment. We've seen paradigm shifts in the management of small renal masses before, where radical nephrectomy was the most common procedure, and now most centers are reporting partial nephrectomies and other nephron-sparing approaches being done. But it still raises the question of whether we're over-detecting and over-treating these lesions, especially the ones under 2 centimeters, and whether in this space, in elderly patients, active surveillance really has a key role, other than a small, single institution things, but as a large protocol where patients are clearly put on an active surveillance protocol with clear timelines and defined endpoints. So the rationale then comes from the fact that some tumors really are unlikely to contribute to cancer-specific mortality, and that a significant emphasis on earlier detection and intervention has not significantly impacted the RCC death rate. And curves like this are very common from the prostate active surveillance literature, that there are lesions we would like to know about, but not necessarily treat, that have a non-progressive or very slow growth. And so it comes back to, again, active surveillance being a potentially appropriate option, but it depends on patient and the tumor. The second objective then is to review, if one was to implement an active surveillance protocol, what are the important considerations to include there to ensure that patients are effectively guided through the protocol. Here, the ideal situation is that a patient is placed on active surveillance, they're well, and they may have a non-cancer related death. And what we want to avoid at all costs on any type of active surveillance protocol for RCC is metastases while on active surveillance, whereas clinical progression, which is typically defined by a size increase, still has all these other modalities that we're all commonly used to and have our preferences to use, leaving after systemic recurrence, systemic treatment still available. Again, there's multiple factors to consider here, and again, what we want to avoid is the risk of metastases while on active surveillance and capture those that progress. And there's some fine nuance in how to determine which types of tumors are more likely to move this way versus not at all, and have a patient stay well on active surveillance. Active surveillance candidates historically are older with comorbidities, as we've seen. It's usually the very small lesions, and it's not offered to young and healthy patients, although this is changing in some of the small series that are reported in the literature. just to highlight here, as this will come up later, these abbreviations are used commonly in many of these papers where patients are either an absolute not a surgical candidate, so they have an absolute reason for active surveillance, or they have potentially a single kidney or CKD or a need for some type of renal replacement therapy after active treatment, or elective where they are a surgical candidate but refuse. And this was a small active surveillance study of 204 patients, 36 of which were on active surveillance. And these authors showed that to almost guarantee active surveillance, you have to have pretty significant criteria: small tumor, terrible performance status, highly endophytic tumor. And again, that would stand to reason most of us would probably watch those as well. But the question is, are there potentially more candidates that would typically be considered fit that might actually benefit from active surveillance? Interestingly, in this study too, they found that patients that were in active surveillance were less likely to have a laparoscopic or robotic trained surgeon. So again, the surgeon factors certainly play into this. Hopkins started a prospective study for active surveillance, but I don't think they've reported yet, and please correct me if I'm wrong if anyone knows, but I couldn't find any reports from this yet. But they're establishing active surveillance with delayed intervention, and they've tried to quantify patient factors to give an objective measure of whether patients are candidates for active surveillance or not. And you can see it's the classic factors that contribute to the most amount of points: age and performance status. And again, patients that have a score of 7 or greater are considered candidates for active surveillance. Radiology plays a key part in any type of active surveillance protocol because, as we said, it's one of the main ways that we can detect and follow these small renal masses. And the goal of serial imaging is to determine the growth kinetics of the lesion, as that typically is the trigger for intervention if it's growing quite quickly. CT and MRI are used as the standard of care, but there is the question of excessive radiation with a CT scan every single year, or twice a year, or sometimes even more frequently than that for a lesion that may not be growing. And if someone is young with many years to live, that's the real question of lots of radiation. And some papers have suggested staggering non-imaging modalities that don't use radiation with CT scan, but again, it creates difficulty in accurately comparing images, which is the goal to determine the growth kinetics. What a lot of papers do, and we'll come to some of these, is to scan every 3 months for at least a year to establish the growth kinetics and the growth parameters, and then space out the imaging as appropriate. We saw the y-axis could be defined multiple different ways. Most papers do put the maximal diameter as centimeters per year on the y-axis, and the growth rates typically don't tend to exceed 0.2 or 0.3. But tumor volume does creep up in a lot of papers, resulting in very concerning-looking graphs. But it's been suggested that it's a better reflection of tumor burden. And just interesting mathematics here, depending on how the radiology report quantifies the tumors and how many dimensions they provide, the volume can be drastically different for lesions that are reported at the same size. So it's an important consideration in how they assess the volume. And I guess ideally we should be expecting 3 dimensions for any small renal mass to best assess single dimension and volumetric changes. Paul Gustafsson recently reviewed in depth the role of biopsy for the small renal masses, and this is some information from his, but in the newer series, biopsies aren't bad. They have a good diagnostic accuracy, a good diagnostic sufficiency, and complications, including the theoretical risk of seeding the tumor, the biopsy tract, are very low and decreasing over time. And biopsy can be good at differentiating benign from malignant, which again, for a patient who you're considering active treatment on, that can save a potential operation for the patient. There's no doubt that biopsy should be strongly considered in active surveillance, but the question is whether it should be used for all patients or selective use. It has been shown that biopsy can help facilitate management. In this study here, patients that received a biopsy, based on the biopsy results, you can see the types of outcomes that they had. If the biopsy was a benign or indeterminate lesion, most patients would continue on blue here, active surveillance, whereas once the biopsy is showing some type of favorable, which I assume means low grade, intermediate grade, or unfavorable histology, then nephron sparing approaches and radical approaches become much more common. So surgeons are using this to help assess whether they need to intervene on a patient or not. and the goal of biopsy is to help minimize nephron loss. Dr. Jewett and Finelli, whose prospective trial we'll discuss shortly, had a review in Nature Reviews Urology, I believe, yeah, and they wrote that active surveillance is best achieved by serial imaging with biopsy, and it gives the most information to assess a patient's tumor and to really personalize care in the early stage of the disease. Furthermore, and this is getting more popular over time, biopsy has the ability to use many molecular tests, which can again help differentiate benign from malignant. And within malignant lesions, it can also help assess the grade of the lesion. So you can get a lot of information with an appropriate gauge and appropriate volume, well-taken biopsy. But it's important to mention that these small renal masses, when they do reflect an RCC, can be quite heterogeneous inside, with necrotic areas and different grades of tumor even. And so there's certainly a sampling error when one small 18-gauge core is taken of a tumor. Finally, the other consideration is when to terminate active surveillance. Certainly, we want to terminate it when an active treatment and cure is still possible. But it's very important to note that a lot of these thresholds for terminating active surveillance are just arbitrarily defined and are very different paper to paper. And again, it's because there's no major definition of there's no major predictive mechanism for aggressive behavior of these tumors. And there have been a few editorials that have commented that as you watch these tumors grow, it might make a nephron-sparing approach more difficult. Although most papers still report that once a patient is actively treated, a nephron-sparing approach is still feasible. People have raised that issue that if you're going to treat it anyways over time, it's just making potentially easier partial harder. Typically, when papers do define cutoffs, the typical size is any single dimension greater than 4 centimeters or doubling of volume under 1 year. Most series do report that nephron-sparing approaches are completely feasible still, but it's important to note only 10 to 20% of patients in any individual retrospective or prospective series meet these criteria for termination, but a significant number of them still undergo active treatment, which underlies either patient or surgeon factors leading to treatment. And the importance of follow-up on active surveillance protocols is also key. This was a case report written by Dr. Luke in 2012. And I think this was a patient that was on the Canadian prospective active surveillance trial, recruited in 2007 with a classic 2.5 centimeter lesion, volume 12 centimeter cubed. In 1 year's time, repeat imaging, 3 centimeters now, but I assume the other two dimensions were the same because the calculated volume was only 15, so not a major change, and the patient was lost to follow-up, and then presented several years later with gross hematuria, systemic symptoms, with a 7 centimeter lesion, with IVC thrombus, and again the question is raised, treating it here as opposed to watching it develop into a terrible disease. Is again one of the pitfalls of RCC, of active surveillance, and so the importance of close follow-up can't be underscored anymore.
What was the take-home message on that?
The follow-up for active surveillance.
They weren't making a pitch for early intervention?
No. It was just a one-page thing, and they just said this highlights the absolute strict importance of active surveillance, a follow-up on active surveillance protocols. The guidelines don't state too much on this. I'd actually start with the AUA, which say the most about active surveillance, and they say to consider a biopsy, image at least every 6 months, do an annual screening chest x-ray for METs, and discuss with the patient several important factors: the risk of progression, the window for nephron-sparing surgery, and the lack of cure for metastatic disease if it were to occur. CUA and EUA guidelines are very brief on it and just mention that active surveillance could be an alternative option for the elderly, and that reliable prognostic factors are just not available yet. And the European group combines active surveillance with RFA and just says both are options for elderly with comorbidities. And then finally, I'd just like to review some of the active surveillance series and see how they define these important considerations like surveillance and when to intervene and what defines progression. And in these series, progressors are defined two ways. Again, the ones that progress locally and then go on to have some type of local approach, nephron sparing approach usually, and those that have present with metastases while on active surveillance. This is the enrollment guide for the study that's accruing patients at Hopkins currently. And what's interesting about this is that it's non-randomized. Once patients are considered candidates for the study, they can choose either surveillance or intervention. And the patient actually has the choice to cross over between any group. So it's an interesting design that it's completely patient-driven and non-randomized, but it'd be interesting to show their results when they have them. But once again, their cutoffs are a growth rate greater than 0.5 centimeters per year or any type of symptom. It takes the patient over to intervention. And they do not have an approach to biopsy all patients in this. One of the large retrospective studies that was done on active surveillance patients pooled 880 patients together, only 259 of whom had individual level data to actually plot growth kinetics. But of that, over 20% of small renal masses over time, which was about 2.5 years, exhibited no growth. The reason for active surveillance is I wanted to highlight here because the authors don't explain this in too much detail in the discussion, but most patients in their active surveillance series had electives, which means they were surgical candidates but refused intervention. Very few had absolute reasons for active surveillance. And again, as expected, the typical growth rate was 3 millimeters per year. And again, as seen, while very few people actually met the criteria for treatment, as we saw in previous slides, about 50% of patients underwent intervention after just 2.5 years. And the faster growth of the tumor was associated with the intervention group versus slower growth in the non-intervention group. And of note, of the 880 pooled patients, 18 patients progressed to metastases while on active surveillance, and all of these lesions did have positive growth kinetics, which is somewhat reassuring from an imaging point of view, that the lesions that metastasize also tend to grow. Looking specifically at those 18 lesions that metastasized, they're in more elderly patients, but again, the starting size, the mean tumor dimension, was 4.1 centimeters with an average growth rate of 0.8. So these are lesions that most likely on any formal protocol would have been treated and not candidates for active surveillance. But you see here now it flips, that the majority of patients had absolute reasons for active surveillance, that they simply were not surgical candidates. And despite size mattering and most lesions being large and growing quickly, 1/3 of these 18 lesions started with an initial size less than 3 centimeters. So again, even lesions that are quite small do have a metastatic potential. Another retrospective series, which goes back further and pools more patients, but some of the same ones, once again shows a roughly 20% no growth across all studies and a 1 to 2% metastatic rate while on active surveillance. And again, the patients that had metastases while on active surveillance exhibited rapid growth. So rapid growth is probably going to be, as a single parameter, a trigger for intervention. And this was the Canadian prospective trial, of which UBC contributed some patients, which had 178 patients enrolled and created two subsets from this. One subset was 127, which had multiple serial growth parameters to plot the growth kinetics of the lesions on active surveillance, and patients that were currently still on active surveillance. Oops. The interesting thing about this study, which is unique, is that biopsy was offered to all patients. Unfortunately, though, out of the 178, it was only done in 99, and there was a 33% non-diagnostic rate. So it may speak to the real-world situation with biopsy not being as good as it's advertised in other literature. They did the imaging every 3 months in the first year, 3 months, 6 months, and then Q6 months annually to determine the growth kinetics. And if the lesion on biopsy was benign, then they imaged it only once a year. And their criterion for progression is what we've seen before: a 4 centimeter cutoff, a volume doubling in under 1 year, or obviously those patients that metastasize while on active surveillance. So they plotted here each individual lesion over time, and you can just see the lesions grow, they stay stagnant, some of them decrease in size. But the interesting thing about this is two things. One, in all the groups that increased in size, decreased in size, and remained static, all those groups of lesions had RCC represented in each group. And furthermore, lesions that were biopsy-proven benign, although they started off with a lower tumor dimension, they grew at a faster rate than lesions that were biopsy-proven malignant, which again puts growth kinetics, it dampens the enthusiasm for growth kinetics, but again, it's probably the only parameter that we have often, unless it's coupled with biopsy. Of the 27 patients that progressed in this study, that actually met the criteria for progression, 25 were local and 2 were metastatic. One patient likely had occult Mets at the time of study entry, because with a 2.4 centimeter lesion, the patient presented with Mets at 2 months and died shortly after. And a second patient with a 2.7 centimeter lesion, still under 3 centimeters, presented with metastases at 12 months with a previous normal chest X-ray. The other thing about this study, we saw a previous slide about the importance of follow-up, but this paper just states that 17 patients were discharged from service or lost to follow-up, which seems, again, for an active surveillance protocol for a disease with, significant risks if it were to metastasize, it seems like a high number. And the 33 patients were withdrawn for the study for not meeting the clear termination criteria, but for patient or surgeon factors, and 16 of those ended up undergoing treatment anyways. So this question of patients being treated despite not meeting the strict termination criteria is always an issue. This paper, which came out in Journal Urology at the end of last year, was the one that got me interested in this topic, because they were reporting active surveillance for T1B and T2 renal lesions. So now they're really sitting back and watching very large lesions. So from their cohort of 461 patients, 68 had renal masses greater than 4 centimeters, most of which were solid enhancing, and with follow-up of over 2 years. 45 remained on active surveillance, and 23 were treated. Out of the ones that were treated surgically, those patients tended to have a younger age and a faster growth rate. But again, that growth rate is substantial. What we saw greater than the 0.5 centimeters, which tended to be associated with lesions that metastasize, versus the 0.37, which is more in line with the typical growth kinetics of all small renal masses. And in this series, there's no reported metastases of any of their lesions greater than 4 centimeters so far on active surveillance. But what's interesting here is in the non-surgical group, they had an older age, but the actual range is 45 to 94. So, and again, they don't discuss this in the discussion really, but that means they have a 45-year-old patient with a lesion greater than 4 centimeters who's continuing on active surveillance, which is probably something not many people in this room would do. So it's very interesting how they're watching these lesions. And finally, here at VGH, there's the Small Renal Mass Tumor Board Conference, which is a multidisciplinary rounds done with urology, interventional radiology, and medical oncology. They're all at the same table, and cases are discussed there, either referred from the community or referred from our staff here. And the goal is to determine the ideal management strategy for each small renal mass on a case-by-case basis, taking into account patient factors and the tumor factors. And we have the names and the data for 2012 onwards, but I just wanted to show from 2012 where 51 patients were conferenced, 11 were put on active surveillance, and I just tried to emulate the graphs that we've seen in other papers, graphing the maximal tumor diameter by follow-up. And most patients, especially with the larger tumors, green here means that they actually had a biopsy and it was benign, so clearly at 4 centimeters it was okay to watch them. But most of the lesions that are in the typical range, under 2, under 3 centimeters, there was no biopsy, or a biopsy was indeterminate. And the black triangles here means that the patients were surgically fit, but active surveillance was determined to be the best approach, whereas the orange squares here means the patients had either a poor performance status, major comorbidities, or a previous history of cancer. And just to show again that some lesions just tend not to grow while we're watching on active surveillance, or even decrease in size. So back to the case here. Any changes? Are there people that would? Can we take a poll for active surveillance now for this gentleman? Looks like a few more hands. Okay. so all the options are discussed with him, and he ends up choosing active surveillance, but it's nothing new to him because he's also on active surveillance for his prostate cancer. And so, it raises this issue now of, what urologists are doing. And there's been editorials on it too that, we're watching all these tumors that 10, 20 years ago would have been 2 cases right then and there. And RCC and prostate cancer share multiple factors. It's true that, stage migration over time, potential early detection because of all the cross-sectional imaging, or for prostate because of PSA. And definitely they both share a subset of indolent disease, but it's much harder to define that indolent disease in RCC because oftentimes there's lack of routine biopsy, so we don't know a lot of these parameters. And fewer options are available for patients after progression while on active surveillance, which is less the case for prostate. And again, the question of a cumulative radiation dose, if a young gentleman is getting a CT scan twice a year to follow a lesion. So overall, the pros and cons of active surveillance. The pros is that of multiple small renal masses, many will be benign, a significant number, and the majority that are malignant are a low-grade indolent disease. Metastases, progression to metastases is certainly low, but not zero, and it appears that delaying surgery after a period of active surveillance doesn't worsen the oncologic risk or doesn't worsen the surgical approach, and nephron-sparing approaches remain favorable. But the cons, again, most of these small renal masses do have growth kinetics, which can be worrisome for the caregiver, and many patients end up having the lesion removed anyways, even if they don't meet any objective criteria because of patient or surgeon factors. Imaging is not the end-all be-all, although it's typically the only single parameter that we have to follow these lesions. And a lot of these trials that we went over are small and retrospective. And again, the progression to metastases while on active surveillance is low, but it's not zero. So, conclusions. Small renal mass natural history is still not very well defined, and more papers will be coming out, especially that prospective trial out of Hopkins, to just accurately get a prediction of which lesions would be malignant and which is not. The bias is still towards surgery, and as we said, although only 10 to 20% might meet objective criteria, 40 to 50% still are treated even in a relatively short time frame. But the way it's being proposed now is that active surveillance with delayed intervention is likely to play a larger role in small renal mass management in the future, but we need to better define the candidates, the surveillance strategy, and strict criteria for termination so that things are more homogeneous between different centers and different countries even. So with that, I thank Dr. So and thank you all for coming. Any questions?